Hello, and welcome to anyone who has just joined us. I'm Dr. Andra James, Professor of Obstetrics and Gynecology in the Division of Maternal Fetal Medicine and Consulting Professor in the Department of Medicine in the Division of Hematology here at Duke University. Today's session is on uterine hemostasis. And I'm going to begin with an overview. And I'm going to start by what do we mean by uterine hemostasis? Well, we mean the collection of unique processes that control bleeding at the time of childbirth, miscarriage, and menstruation. And I'm going to start with control of uterine bleeding during childbirth. And the most important factor is uterine tone and vasoconstriction. And it is enhanced by the hypercoagulability of pregnancy. So we'll spend a minute on uterine tone and vasoconstriction. The evolving placenta invades and dilates spiral arteries in the uterus. Spiral arteries are the terminal branches of the uterine arteries. And in this cartoon, on the left side, you can see a depiction, not to scale, but of the non-pregnant spiral arteries. And on the right side, you can see a depiction of the pregnant spiral arteries, and you can see that they are much larger, have a greater caliber, and that blood coming in through the spiral arteries is coming into the uteroplacental space. Now, no matter how advanced gestation progresses, at the conclusion of pregnancy, the placenta should separate from the wall of the uterus and be expelled. Now, separation of the placenta is associated with exposure of those open spiral arteries and potentially bleeding across the entire surface previously occupied by the placenta. And the mechanism by which bleeding from these vessels is controlled is predominantly contraction of the uterine musculature. And for the process to succeed and bleeding to be controlled, the placenta must be expelled by uterine contractions and the walls of the uterus approximated, sealing the cavity. Contraction of the interlacing muscle fibers of the uterus results in external pressure on those open spiral arteries. But other factors not completely understood lead to vasoconstriction of those open vessels. And combined, they are the primary mechanism controlling bleeding from the uterus at the time of childbirth. But this process is enhanced by the hypercoagulability of pregnancy. And what are the contributions to the hypercoagulability of pregnancy? I think we are all familiar by the increase of clotting factors contribution, but there's also a decrease in at least one of the natural anticoagulants. Something that we don't always appreciate is that there is an increase in platelet size and reactivity, and there may be a decrease in fibrinolysis, especially around the time of childbirth. So what are those changes in coagulation factors? Well, particularly noteworthy is a significant increase in fibrinogen, factor VIII, and von Willebrand factor. This is work from Jill Johnson's lab and demonstrates the significant increase in von Willebrand factor and factor VIII during pregnancy with the rapid drop-off after delivery. This hypercoagulability of pregnancy is at least partly mediated through the hormones of pregnancy, which figures into our presentations today. And then what about the control of bleeding at the time of miscarriage? Well, as I said earlier, no matter how far in pregnancy gestation proceeds, at the conclusion of pregnancy, whatever the gestation, the placenta needs to be expelled from the wall of the uterus. And before term, although smaller, the placenta may not separate as easily or completely, and this may be a factor in hemorrhage associated with miscarriage and in some cases, preterm delivery. And what about control of bleeding at the time of menses? Well, during the menstrual cycle, the lining of the uterus, figured there on the bottom row of this cartoon, otherwise known as the lining of the uterus, this endometrium undergoes preparation for a possible pregnancy. If fertilization does not take place, the level of progesterone drops, spiral arteries constrict, the outermost or newest layer of the endometrium necroses. And during normal menstruation, normal uterine hemostasis is maintained in the face of this necrosis by spiral artery vasoconstriction and normal coagulation. So the same hormones that mediate the hypercoagulability of pregnancy also participate in the menstrual cycle. They enhance hemostasis at the time of miscarriage or childbirth, as well as menstruation. They suppress ovulation. They can be used exogenously in hormonal contraceptives and menopausal hormone therapy, and they increase the risk of thromboembolism, particularly estrogen. We have 4 presentations today. Women and Girls with Hemophilia, presented by Sarah O'Brien. She'll talk in her presentation about the increased risk of uterine bleeding at the time of menstruation among women and girls with hemophilia. I'll come back and talk to you about the management of delivery in women with hemophilia and the increased risk of uterine bleeding at the time of childbirth. Dr. Naomi Tepper will talk about thrombosis and exogenous hormones, and particularly the increased risk of thrombosis with hormones whose natural version would be protective against obstetrical hemorrhage at the time of childbirth. And then Dr. Garavapalli will finish us up talking about thrombotic microangiopathies and about the increased risk of them precipitated by the endogenous response to placental ischemia and the consequent risk of hemorrhage at the utero-placental interface. Thank you very much. It's been a pleasure speaking to you just now, and I, like you, look forward to the next presentation.